Good morning, everyone, and good afternoon. It's Dr. Tofi. Welcome to HerniaTalk Live. We are starting our new year. It's our first Tuesday of the year. So as usual, we're here at HerniaTalk Tuesdays. My name is Dr. Shirin Tofi. I am your hernia and laparoscopic surgery specialist. Many of you are joining me via Zoom Live, others via Facebook Live. Thank you, everyone, for following me on Twitter and Instagram at HerniaDoc. And as usual, at the end of this session, you can follow me and watch this episode as well as all the prior episodes on YouTube at HerniaDoc. So today we have a great guest. We have a little bit earlier Hernia Talk session because our guest is currently in Copenhagen, Denmark. Dr. Hans Friis-Anderson is a good friend of mine. We see each other as much as we can, at least once a year at the European Hernia Society meeting. He is a hernia surgery specialist. You can follow him on Twitter at GASTHFA. And just want to thank you so much, Hans, for joining me. It's 9 o'clock your time, PM.
It's dark as pitch black.
So before we went live, we were just talking, and Denmark is a beautiful country. It's a great country. Different medical system than the United States. And what's very unique from a hernia standpoint is you have a very, very robust national database, which we don't really have in the United States, at least not in any way near yours. So I really want to learn from that because you are the head of it and you've been so involved with the database and all the research that comes out of it and everything we learn from it. And we get a lot of questions about, well, how do you know? And we don't really know. And when patients are wondering, like, what's this percentage of this recurrence? What's the percentage of that chronic pain? And the fact is we actually do know in certain countries. And then hopefully we'll review this. So quickly, just very briefly, what is your practice like in Denmark? And maybe you can tell my audience like what the medical care kind of is in Denmark. So socialist medicine, is that correct?
Yeah, it's you could call it a socialist medicine system. Nobody pays for going to the hospital or going to their general practitioner. You pay for medicine, the medicines that you need, and you're paid for your dental work. That's it. Everything else goes through taxes. It's the same.
How high are those taxes?
Oh, don't talk about it. You're going to make me cry.
More than 50%?
Yeah.
Oh, wow. Okay.
I currently pay 52% brutal.
Okay.
Yeah. But apart from that, that's not what we're going to talk about, is that, we're a very small country and we are the most digitalized country in the world.
Okay.
So every person in Denmark has a unique personal identifier, a social security number, as you could call it. Yep. And then we have at least 70 different databases covering different areas. And we have a hernia database that turned 25 years this year.
Wow. Congrats.
So we're going to have a party in the next summer at our yearly meeting.
Yeah.
So the system works like this, that based on diagnosis and treatments and complications after the ICD coding, we put things into all these different databases. Mm-hmm. And then we can follow people from birth to death.
Very interesting.
Because they don't go from Virginia to Alaska and and things like that. They, even if they go outside of the country and come back, they will still have the same identifier and we will be able to track them. So,
so you're born with an identifier, and then most people in Denmark don't leave Denmark. No,
but then again, I mean, there are probably about 300,000, at least 300,000 Danes living abroad.
Okay, and they're not.
It's not that many, but out of 6 million, it's a number.
Yeah.
Yeah. Anyway, so we put things into the database.
Yeah.
And when we look at hernias, we started out with an inguinal hernia database back in 1998.
Okay.
And in 2007, we added on ventral hernias. So we haven't been going on for that long with ventral hernias. And then again, you know, when you look at databases and if you compare it with the German HerniaMed, Germany is a country with 80 million people. That's almost 14 times more than that there is in Denmark. So the numbers will grow fast in Germany.
Because
So
your country is only 6 million?
Yeah.
That's like 2 Los Angeles counties, 2 Los Angeles cities. Oh my God.
Exactly. Or Houston, greater Houston area.
Yeah.
So when you need to look at databases and the science you can grab from that is that this is not a randomized single small controlled study where everything is the same and where the internal issues are very few, and in database the external issues are very large. So they give a much more precise picture of what the world looks like.
True.
And so we don't record recurrences, but we record reoperation for recurrence.
Reoperation. So as a surgeon, you see a patient and you diagnose them. Do you physically put in the information, or is there someone that does it for you?
I've put it in I put it in myself physically. Currently, we are working on a system where the databases will grab the data they need from the patient records, but that's not in place yet. But that's probably going to be machine learning or machine reading, but it's in the beginning. And
then let's say you do the surgery. Let's say you do a laparoscopic inguinal hernia repair. Yeah. Do you personally also record that surgery, the date, what it was up, and so on?
I personally do that, all of it myself.
And then how much detail are you giving? Like, yes or no mesh, and then do you know what kind of mesh, or
we do what kind of inguinal is it, the type of inguinal, the size of the inguinal, what type of procedure you do, whether you do open with or without mesh, whether you do laparoscopic, what type of, will you do TEP or TAP. We do all these things, so you know everything about this about the surgery itself.
Like a dream.
And we will register the type of mesh that we use. But then again, looking at differences, if you take 10,000 operations for a hernia and they all get a mesh, and you have 40 different meshes in the market, and people use them, then it will take forever to have numbers that will show differences in mesh outcomes.
Among the different meshes.
Yeah, exactly.
Got it.
So for instance, we were the ones that showed that the fissure mesh was no good.
Which mesh?
Johnson & Johnson's fissure mesh.
Yes, correct.
That was retracted based on data from the Danish hernia database originally.
This is very important because I don't think our audience, I don't know that we've actually discussed this. We may have. So usually a mesh is introduced after they've gone through phase 1, 2, and 3, maybe studies, and then maybe a phase 4 study, which is after it's marketed, they still follow the outcomes.
Yeah.
And that may be hundreds to thousands of patients, and they're followed for maybe 1 or 2 years. Yeah, and exactly. In your database, you were able to show, based on your own data, that a certain mesh, which was brought up by Ethicon, which we all thought was a great idea because it was thin and
fantastic mesh.
Anything, it was like a perfect mesh, right?
Exactly.
And
addressed all the applicability issues, all of them all together.
Yeah. So
direction, see-through, clinging, easy to fix.
It won't stick to anything, and it's super lightweight. You don't have to worry about burden of mesh and all that. It didn't have the ring that some of the other meshes had problems with. And we started using it. We're like, this is great. And the studies look like patients tolerate it very well. And then you showed I think it was laparoscopic.
Only laparoscopic.
Specifically, where it was way too thin. You can be too thin of a mesh, right?
Yeah, but it was also causing a lot of adhesions. So there was, and when we look at it, when we had this discussion at the meeting in Copenhagen where you weren't last year, the issue is that we don't have the resources to do constant surveillance of how the mesh works.
Yeah.
You need AI to do that, and we don't have that. So what we do is that we go down and we make a spot on at a certain point of time, and then we'll do it again. And when we look back into time, we could show that when you compared at IPOM meshes, all the other IPOM meshes with fissure mesh, after 100 implantations, you could see that there was something wrong.
Yeah,
but we waited for years to get the data and to get security for that the data was sound.
Yeah.
It had to be significant.
And let me ask you this. Did Ethicon remove the mesh after your publication, or
after we gave them the data? They removed it in connection with the Rotterdam meeting in 16.
Yes. Yeah.
In May 16. Yeah.
Yeah, very unique, because this was not a adverse event. Like the FDA, there's adverse events. The government didn't get involved. This was purely, look at the data we're showing. It's a national database. And within hundreds of patients, you were able to show that it wasn't performing the way that we thought it would perform.
And then it was backed up by the HerniaMed in Germany, by Friis-Anderson as well.
So right now in Europe, we have the Swedish, the Danish, and the German HerniaMed Registry.
And actually, you know, the people in the United Kingdom and Ireland, they just they're going to introduce a complete copy of the Danish hernia database from the beginning of next year. No, this year, sometime during this year, they will start a complete exact copy of the Danish hernia database in both Ireland and the UK.
Does the government pay for maintaining the database?
Yeah, in Denmark it does, but in the UK they have to get resources somewhere.
Yeah, that's always
and
been
that's still one of the big issues. But they have the same. Yeah. They have the ability with a unique identifier that they can follow people
for life. This is for the life of the patient. Yeah. So you're aware the United States has recently, I think it's 5 or 6 years, started the ACHQC, so the American.
We see data. We see a lot of data from that database.
Abdominal health, yeah, the abdominal health, core health, quality collaborative, ACHQC.
Exactly.
Are you familiar with the ACHQC compared to your database?
Yeah.
So one thing that I like about it is very granular. Like, how many stitches did you put? How many tacks did you put? Which tack did you use? Which mesh? What size mesh? Where exactly you put the mesh? There's a lot of details technically in it that are very, very detailed.
Yeah, I believe that perhaps the number of tacks or the number of stitches are not that issue. That they're not an issue, but I believe that choice of mesh and choice of fixation is an issue.
Yeah.
And
like
we're just
not put a drain. Yeah.
We're just going to publish a study we've done on emergent, only on taps in Denmark, comparing different meshes and different fixation devices. And it looks like that the best way to go is with the mesh from Medtronic, you know, that fixes itself.
Yes, the Friis program.
Yeah. But we still need to do some data statistics to be quite sure.
Yeah, it's fascinating. The problem with the US one, I belong to it, so I put all my data there. It's very good. You know, it'll tell you tissue repair, what type of tissue repair, did you do a component separation, not a component separation, etc. The size of all the defects. But you know, in the United States, I don't know if it's like that in Denmark. Maybe the culture is different. The majority of people doing hernia repairs are not part of this database. Majority. Yeah. We have, I think, under 1,000, maybe even under 500 surgeons that are using the database. So our volume is high, you know, but the percentage capture is low. Yeah.
But in Denmark, there's a law that you have to do this. And our registration rate is above 90%.
Oh, wow. Yeah, we don't like laws in the United States. The
No,
freedom
but-
is freedom of practice.
Freedom of speech. I can do
Yeah,
whatever I want to.
kind of.
We
The
can.
other question is, so the ACHQC is dependent on the patient constantly updating. Like if they have a recurrence, it doesn't follow the patient necessarily because it's not national. So they go to another surgeon, it won't capture it. So it's dependent on the patient also putting in like, oh, I was just hospitalized, I had a fever, I have pain now, or I had to have the repair redone.
We don't have patient data yet. We are working on trying to get PROM into a preoperative PROM and a postoperative PROM combined with the data we put in there. But that's still in the working.
Patient report outcome measures.
Yeah, exactly.
Yeah, so that's a problem too, because patients really want the data, but the reality is they don't fill out these forms. They don't fill out these emails. The response rates are very low.
So we have what we're working with is a red camp system that is bombing them every 2 weeks until the end.
Yeah, you just start deleting it, the emails. It's a problem.
Yeah, but we can only, the whole issue about PROM is that we've always said the doctors have always defined what's a good result and what's a bad result, but nobody ever asks the patients.
So I have something for you. I don't know if you have Yelp or Google reviews or other kind of online review system of doctors in Denmark. Do you have that?
No.
So we have that. You can go to a restaurant and then you review the restaurant online, say, oh, it's great food, or the valet parking is too expensive. They have the same thing for any business, including all doctors. So doctors can be graded, and you can say, oh, my doctor was so great, and or you can say, their office was dirty, or I didn't like the front desk person, they put me on hold too much. They can say whatever they want. And patients actually find it valuable to go either on Google or on this app called Yelp. And there's other ones like Health Grades, Vitals.com. These are all different apps that are review apps. They review doctor experience.
That's not common in Denmark.
That doesn't happen.
Your system is primarily based on the fact that the majority of you are in private practice. So you have a business to run.
Yeah.
I'm a hired gun.
Yeah.
So when people complain, they rarely complain about the doctor. They're complaining about the department or the treatment or something else. And we have a system to handle that. And they will get remuneration if we think that's relevant. And it's not caused on culpa, so you're not supposed to be guilty of something. It's only if something happened that generally would be unlikely to happen that they get a remuneration. So we don't have this personalization of the issue.
Yes.
Of course, you can get a complaint about you as a person, but that generally goes not on your skills, but as that they think that you're an asshole.
Yeah. Okay. Well, there's a new program called Outcome MD that rates doctors based on their outcome, not based on like if they have someone who answers the phones on time. So it's fascinating because as a patient, I would want to go to get my hip replaced by the one who has the best outcome for the hips. I don't care if it's like nice or not nice.
Where does the app get the outcomes from?
Patient reported.
Yeah. And can you be is that realistic?
So, for example, there are some validated questionnaires on quality of life and outcomes related to certain operations.
Yeah.
And the patients fill out those specific questions.
Yeah.
Can you walk? Do you have pain? Do you need to take pain pills? Are you able to clean yourself? Those kind of things that are validated for each operation. So like the Carolinas comfort scale for hernias.
Yeah.
And then the doctors are rated based on how high they score on average for their patients who have these operations.
Yeah, but it's a flaw that you don't know which percentage of the patients actually do this on each
Sure.
doctor.
Sure.
So you're,
Yeah. You can have one patient and get 100%
and
score.
wow. I can give you a funny example of
That's
that.
true.
You have this online and paper surgical newspaper in the
General
US.
surgery news.
Yeah, and in Denmark we have something called Medicine DK, and every year they look at different issues, and then they will tell the people that this small hospital that did 22 umbilical hernias last year is the best in Denmark. And the one, and we that did 600 and had 99.7 instead of 99.8, we were next best. So, you know, these things are crazy.
Yeah, true.
The quality of this should be measured in a completely different manner.
Well, okay, so very good. So your database also tracks who the surgeons are.
Yeah.
Have you been able to show?
Yeah, we can show differences.
I know that you show. Yeah, the differences.
We show differences, and then we look into departments of specific operation types of operation, for instance, TAP, Liechtenstein, whatever it is, and we will go through each department and see whether there are outliers, and if there are outliers, we will talk to them in the hernia database, doctors.
Very good.
Yeah, and we can do that with doctors as well.
And do you consistently show that higher volume surgeons are better, or is it not necessarily volume?
It is a combination of volume and experience.
Okay.
Yeah.
Yeah, because we have a lot of people that in the United States that live in areas where they don't have access to experts. You know, they live far away from the main town and so on, and they're relying on their local surgeon. And I always tell them, especially now that you have telehealth, get a second opinion. Surgery, you should always get a second opinion, even small ones, because then you're going to regret, you know, why didn't I know this or that? But if you talk to an expert, they may give you a different analysis based on their experience than someone who, you know, just has no interest in hernias, but, you know, just does a lot of hernias all day.
Yeah.
Right?
So again, you know, 10,000, 11,000, 12,000 inguinal hernia or groin hernia surgeries in Denmark a year. In a few private practitioners and private hospitals, and in 22 surgical departments.
Yeah.
And we do 1,000 in my department.
Yeah.
So we do about 1,600 hernia surgeries a year.
In your department?
Yeah.
Yeah. There's a live question. They're asking about watchful waiting. So does your database capture watchful waiting?
No, but it's going to do that.
Okay.
But we are now going from one database system to another one. And context for that, we are going to add on with a number of issues that we need to explore. So that's one of them. But
the diagnosis of hernia will be captured at some point. You can track what happens between diagnosis and surgery, right?
That would you could do that. But the problem with that is that what happens with the general practitioner does not go into the ICD coding system. So they need to be submitted to a hospital for evaluation for you to get the hernia diagnosis.
Oh, okay. Okay.
So we are working on that as well.
Interesting.
Because that would give us a lot of new information about, for instance, post-operative pain, and how often it exists, and how long it exists, and what type of how it is, and stuff like that.
Correct.
Because when we look, for instance, at chronic pain after inguinal hernia surgery, whether laparoscopic or open, we tell them 10%, but the real number is probably for severe problems about somewhere between 2 and 5. depending on the time lap after surgery. But if we look at 10% within the first year, and we do 1,000 of them, there should be 100 patients sitting in my outpatient clinic complaining of pain the year after, and then they reduce over time. So I would probably have to have 2 consultants to look at both and the people with pain, and I don't. We don't pain as pain problems that much.
Yeah,
and And relating to that, you know, the whole issue about mesh and mesh complications and mesh being the mother of Satan.
Yeah,
it doesn't exist in Denmark, because we've been registering mesh in inguinal hernias for 25 years.
Okay, so this is very good information, because they're always asking me, like, how do you know, and so on. So your database has been capturing 25 years prospectively of mesh database since the inguinal hernias, right? 1998. And what's the penetration of mesh use for inguinal and ventral in your country?
It's in Liechtenstein, it's, I mean, people, everybody gets a mesh.
Okay.
One kind of mesh.
So Schuldeis, Bassini are not very common?
There are very few Bassinis or Schuldeises, but that's it.
So and either open or laparoscopic.
And we don't do TEP. So in reality, we have standardized groin hernia, inguinals into TAP or Liechtenstein.
So open Liechtenstein with mesh, laparoscopic TAP with mesh. Okay, that's fine. And then for inguinals, now I'm going to just stick with inguinals. What does your database show? You said 10%, any pain within a year?
Well, the data, you know, this is 1 year data. This is about 10%. And when we look at it, and we look at the pain problems in a group of patients from the database, not all of them, but we pull out a portion of the patients and look at them afterwards. It's obvious that Liechtenstein have more pain in the beginning, and TAPs have less. But at about 4.5, 5 years, they're the same. And that's about 3-4%.
3 or 4% chronic pain.
Yeah,
4 or 5 years out.
5 years out. But you need, you know, this is a study where you ask people whether they have problems, any kind of problem.
Yes.
So the severe problems would be much less out of the 3 or 4%.
That's really important information, because most of the data where we look at for pain, it's any pain, and it's not granular to say I specifically have testicular pain that's preventing me from, you know, having sex, or I can't sit down. Like, that kind of pain is not 10 or 12% or 20% or a lot of the stuff that are out there.
Exactly. And this is all any kind of pain, including testicular problems for men. But this is the whole group. So the numbers are much smaller than they seem to be in the literature. And these data have been published from the Danish hernia database.
Yes. Yes. So it's fair to say some type of pain likely related to the hernia repair, we're assuming, well, we don't even know that. At 1 year, 10%, at 4 to 5 years, 3 to 5%.
Yeah.
Okay. And then open surgery is just as good 4 or 5 years out than laparoscopic.
Yeah, they have the same recurrence rate. No, I can't say the same recurrence rate, but probably the same recurrence rate, because we don't register recurrences. We only register reoperations for recurrences. And those are 4% whether you do TAP or Liechtenstein. Got it. And we have looked into a cohort of patients and looked at them over time. And when we look at them, then the real recurrence rate is probably in inguinals about 3 times higher. So it's 12%. For open versus recurrence, for both. I'll say that one more time. It's about 12% for both open and lap inguinals.
Lifetime
The
recurrence.
real recurrence rate, no, within the observation period.
Okay.
The Kirkling has just published a paper last year or the year before that, where they looked at how long should we look for recurrences in the
Yes.
groin, and he says 50 years.
Yeah.
And in ventral, they say 10, 12 years.
See, we had this discussion a couple weeks ago. You know, for breast implants, they say every 10, 15 years you should change them. They last 10 years.
Yeah.
For hip replacement, you know, or knee replacement, shoulder replacement, oh, it only lasts 15 years. You have to come back for replacement. But for mesh, we say lifetime. You should be fine for your lifetime, and there's no life to it. So this whole 50 years situation. What do you think is the right thing we should say about how long a hernia repair should last?
I really don't know, because, you know, this is really something that is, I think, is based on what type of mesh it is. We have seen that some of the meshes, that they get brittle over time, and suddenly, people have recurrences at a later point, even though they had a mesh. And for instance, the Johnson & Johnson, the one with the blue lines on it, I can't remember.
Ultra Pro.
Ultra Pro, yeah.
Yeah.
That is too light. And you
Very
know,
light.
the newest data that's coming out of in the new guidelines on ingranals and mesh, they're going back to heavier weight meshes.
Yes.
But still large pore.
Because the recurrence rates are too high.
But to avoid encapsulation and then shrinkage, and due to that. So you know, I've done a lot of mesh studies, but on IPOM meshes in sheep.
Yes.
And I can say that there has been a tendency among surgeons to think that a mesh is a mesh is a mesh, and a fixation device is a fixation device, and it doesn't matter. But we have shown in several sheep studies with the different meshes and different fixation devices that meshes react differently when you put them into a sheep.
Yes.
And if you put in a ProTac or you put in some other thing, they will react differently. So a mesh and a tacker is a combination that you need to expand on and investigate. Otherwise, you will make serious mistakes. So you can't just say, this is a mesh, I have this tagger, this is going to be fine. You can see, for instance, the Pyatex Comp, the Medtronic mesh for IPOM, that now became Sympatex, because they made
Sympatex,
they made the basic of the mesh monophilic and not braided.
Lightweight, yeah.
That shrinks 50% area-wise within a year.
Wow.
So if you put in a 10-10 mesh in a sheep, it's going to be 7-7 a year later.
Wow. So do you think the resin makes a difference, like polypropylene versus polyester?
Yeah, I think there's a difference.
Okay.
And especially when, you know, polyester was braided before. When you looked at all the Medtronic meshes with polyester, they were braided. Now they're monophilic. And that's made a huge change for the outcomes of patients with polyester.
So braided versus...
Yeah, braided includes increased risk of infection. And
Bruce Ramshaw's original studies showed that the way each patient reacts differently to the same mesh as well.
Exactly.
That's a problem that we haven't been able to overcome.
Then we need to go into tissue types. I mean, that's not possible. I mean, but I think that you know, in Europe, that now there is a new rule of the law concerning implants.
Yes.
That said no implant can be used. It was supposed to be implemented a couple of years ago, but they're
Yeah.
behind. But all the old meshes are probably going to be chucked out, and they will only work with a few meshes in the future. And then
With human trials.
Yeah, and then they will ask for human. If you want a new mesh to be implemented and used in patients, you will do a trial before you let it go. And they will have to do that too with people that have a database, because otherwise nobody knows what's going to happen.
Yeah, it's a problem because who's going to pay for the database outside of established ones like yours?
Exactly.
That was an issue. I remember we discussed this I think it was in Hamburg in 2019. We're like,
exactly.
what are we going to do? Who's going to pay for it? How are we going to follow through? This is the lifetime of the patient. Is industry going to pay for it? Are countries supposed to pay for it? Does the patient pay for it? These mandated.
I believe that the companies should pay for it, because they have no, and with the current issues about GDPR and patient identities and security and stuff like that, the company can't handle that issue with getting the data and looking at them on a regular basis. So it has to be in a public sense, but since they are selling this, and I mean, if you look at these IPOM meshes,
very expensive.
There's a little coating on a piece of mesh, and then suddenly it's 20 times more expensive than the same mesh without coating.
Yes.
I mean, they make a lot of money out of this.
They do.
But they should at least be part of the financing.
A lot of companies are pulling out of Europe because it's not financially feasible for them to go through the human clinical trials to market their mesh in Europe.
Yeah. And so what we like about that is that now, if Frederick Hellstrand, when he was doing his dissertation, he said ventral hernia is a complex issue because we have these 10 or 20 different types of ventral hernias. And then we have these 20 different ways of doing it. And then we have about 100 types of mesh.
True.
Or no mesh. And then when you start combining it, there's thousands and thousands of variations. And how are you ever going to figure out that? But one of the ways of getting rid of that issue is to getting rid of all those meshes.
And streamline.
Yeah, exactly.
Now that we know more.
And that's what we're doing right now. In Denmark, we have a tender on meshes, and you're not supposed to use anything but that wins the tender.
You're not supposed to use how many?
You have a tender, and you look at the handability, price, and quality.
You can't just introduce whatever you want and charge.
And then we look at these are combined in a mathematical model, and then one mesh will win, and then you generally have 2 or 3 meshes. So we have reduced the number of meshes that you can use to a minimum compared to what it was earlier.
Yeah, true. There's a question about watchful waiting. So what are your thoughts about watchful waiting?
Well,
specifically showing, at 5 to 10 years, about 2/3 of patients end up needing surgery anyway.
Yeah, it's, what we really know about watchful waiting is based on the American guy, Patrick Fitzgibbon's study and the English study. And they both have 10-year follow-ups.
Yes.
And on those, you see that about 60-70% of them end up having surgery anyway.
Correct.
And then actually, I think the British one showed that if you were over 65 and had surgery, you had an increased late surgery, you had an increased risk of dying from it.
Yeah.
And the whole issue about watchful waiting is the doctors are scared of giving people pain longer than they need to. So if they don't have, we have a standard that says no or very few symptoms, you can go for watchful waiting in the groin.
Correct.
We never do that in women, but we do it in men.
Got it. So for males of whatever age, no symptoms or minimally symptomatic, watchful waiting is provided, but not for women. We have no data for women.
No, but we know that women are much more prone to have femoral hernias.
Yes.
And, you know,
Okay.
we just looked at emergent hernia surgery, about 30,000 patients in the whole group was 30,000 patients. And out of that, there were 2,700 emergent surgeries over a 7-year period in Denmark. And 1/4 of them are females.
Wow. Yeah.
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 And who are the patients with the femoral hernias?
Yeah. Women have the femoral hernias.
So going back to the women have 3, 4 to 6% inguinals compared to men.
Much lower. Yeah.
Then they actually are a much larger part of emergent inguinals.
Yeah.
Yeah. So our attitude here is that we do taps on women, and we do it laparoscopically, and we do it actually in fast track. So if a woman is submitted with a hernia and a bulge in the groin, we will generally see them within 2 weeks, and we will try to operate them within a month after. So
to reduce the risk of emergency surgery in women, because that's a problem. Well, that's really good. And question about your, there's an anesthesia question here. The people who get open surgery, do you use general anesthesia or IV?
We do, and I start to begin to think that we are the only ones that are still doing it. But, you know, Henrik Kienitz showed in a study back in 95 or something like that, that you, at a consecutive 500 patients, all ages above 18, could be performed in local anesthesia with IV sedation. And it was no problem. Yeah, it is great. But looking at what really happens is that everybody did it for a while. And now there's a trend that more and more people have primary taps, laparoscopic. So
laparoscopic, which is general anesthesia.
Yeah, in general anesthesia. And so fewer and fewer have an open hernia surgery primarily.
Yeah.
And then the problem here is that the fewer the primary open hernias that you get, then it's going to be a specialist operation to do an open inguinal, which is originally a basic open surgery training operation.
Yeah, I see that.
So there is a political issue here, is what's going on and what's not going on. But I can see that over the years, at least within the last 10 or 15 years, the number of patients operating in local anesthesia in Denmark is gradually going down.
Interesting. That's very interesting because, you know, we're having a big debate here about robotic surgery in the United States.
But, you know, robotics and inguinals, they're good for training, and they're good for if you have a very complex case, if you have had a prior surgery, prostate matter, stuff like that, and there might not be any peritoneum down there, then it's probably it's a very good option. But it's a standard operation for inguinals. I think that's shooting birds with cannons.
Right, I agree with that. See, however, in my hospital, there was only me and 2 other surgeons that were doing laparoscopic inguinal hernias. However, with the robot, now there's like 15 people doing MIS inguinal hernias. Now, I don't know how good they are because I don't go in their room to look, because I think they'll get nervous if I walk into their room while they're operating. But the good news is the robot is encouraging more minimally invasive surgery. But it's got to the point where not just for inguinals, but for like gallbladder surgery and appendix surgery, these are considered like low-level, simple operations. The residents are not really learning how to do open anymore. So when I do open surgery, I do open tissue repair, I have to teach it to them. They've never seen it before. Open gallbladders, open appendicitis, they don't even see it anymore. And it's almost like you said, the older open surgeries are now being done by experts. And the more kind of technologically advanced operations, everyone's kind of learned how to do it because technology has made it so much easier to do.
But you know, we are very cost. We worry about cost.
Yeah.
And if we look at what we use, how much money we spend on healthcare in Denmark, and by the way, everybody has healthcare. So we use about 7% of BNP.
Oh,
Healthcare in Denmark for the whole population.
wow.
All types of treatment, in and out of hospital. So general practitioners in there as well. And then you look at the cost in the US, where what 1/3 of the patients, people don't have health care.
Yeah.
Yeah, that's 20% plus.
Yeah, much higher.
And so this is and you have all these companies working together, the HMOs and stuff like that, that decide what you can do and what's costs. And I mean, they're there for making money. They don't give a hoot about the patients or you guys.
It's horrible. Yeah.
Yeah, this is private enterprise.
This is
but
true.
It's only good for the people that are making the money.
Do you have private practitioners in Denmark?
Yeah, we have typically single surgeons working with endoscopies and small surgical operations, inguinal hernias, umbilical and stuff like that. And then we have private hospitals that have been growing quite rapidly the last couple of years due to Corona and issues with nurses and stuff like that. Staffing is a huge problem right now.
There's another question here about hernia size. If you're doing watchful waiting, do you recommend regular ultrasounds to watch the growth of the hernia?
No.
Yeah, no. By symptoms, not by size.
What we say to people is that if they have a small hernia and they have no symptoms or very few symptoms, so we tell them if you suddenly start having symptoms, or if it starts growing fast, or it's both happens, then come back. Why would you want to do, as I'm doing a lot, ultrasonography on a regular basis to follow the size of the hernia? That's crazy.
Doesn't do anything.
It's a money maker.
Yeah, I agree. So going back to your database and the chronic pain or the pain follow up, here's a comment that says underreporting of pain is a fact. Too many patients are told to be put up with discomfort and that the mesh is not removable. What are your thoughts on that?
It's true, but as I said before, if we should follow the data with the 10% in 1 year and they're going back to 4% in 5 years, then us doing 1,000 groin hernias a year, we should have hundreds of people coming complaining about pain.
Yeah.
And we don't.
Yeah.
At any given time, we perhaps have 10, 15 patients that's in a process of getting, we're mapping them, trying to give them steroids, trying to give them local anesthesia, they get painkillers. And if none of that works, we have centralized the more advanced examinations and operations for this in Copenhagen. So early on, everybody would take out their own mesh. And that work resulted in not the patients, but the doctors that operated them. And that resulted in horrible results. So now we've centralized that. And they tell us that, for instance, what David Shen does doing the laparoscopic nerves transection is that it's a horrible thing because they get really lateral bulging.
Innervates,
If you have to do something, it has to be locally in the groin.
Yes, correct.
Otherwise, it's wrong. And they take out mesh as well. But we don't. We only take mesh out if it's infected.
And what kind of
recurrent infections and fistulas, and once in a while we see a TAP patient with an abscess long after they had surgery. But otherwise, this issue
are uncommon for the groin.
I agree that it's underdiagnosed and undertreated, But there is a gray zone here that we know nothing about. And that's one of the issues that we're trying to put into the database by getting prompts post-operative.
The patient report outcomes post-operatively, yeah.
Exactly.
And do you do any special testing, like to weed out who will do best from like a mesh-based repair than others, like inflammatory blood testing?
No. I followed some of your publications and meetings online about this issue, and this is we don't have the facilities to do this. It's very expensive to do these testings.
Most tests are not available anyway. They're like
but we are discussing whether we should try to implement that. But you know, if we need to do testing, and we from patients that have pain can see that there are certain tissue types that are prone to get pain, or certain reaction from polypropylene, for instance.
Yeah.
Then perhaps you could start testing people beforehand, but it's so rare. And to find the one that gets a lousy result, you need to test everybody.
Correct. So
that's going to add enormous costs to the whole process of handling groin hernias.
Does your database, can it capture people that are adversely reacting to the mesh? Not like mechanically, but like systemically? No, it doesn't. Yeah.
We don't have that option.
And
I still think, I mean, taking into consideration that we've been registering 25 years, 10,000 patients a year, 250,000 patients. And we don't have that. We don't even have a patient group that are complaining about mesh. It's something that exists in the UK and the US.
Yeah, US, UK, Australia. Yeah.
Exactly. But in Denmark, it's not, I'm not saying it doesn't exist. And I'm very open to the idea that some people will be more prone to get reactions to it. But I do believe that trying to figure this out is going to be very lengthy and extremely costly.
Yeah, I agree. One day we'll have the funding to be able to maybe do something, because we don't know enough. I can't predict who's going to.
And then again, if you have something, you have something that induces an inflammatory response or an allergic response to something, and then if you take it out, you would expect that to stop.
Yes.
So I don't know. It's there is so little knowledge about this. No, we don't know it sufficiently to make.
Yeah, we're having some questions here from one of our advocates who's very involved in this research, and so she's wondering, maybe we should just look at least maybe a subset of patients, so all the patients with known autoimmune disorder, let's say, and at least like look into them. Problem is those tests are all research-based. HLA is not research-based. You can order those, but it's very expensive. United States, they won't pay for.
But you know, there you could say that if you have patients with autoimmune diseases, for instance, no matter what kind, you could say Crohn's, whatever.
Yeah.
Then we could combine the databases, and on the social security number, we can identify whether there are people there, and whether Crohn's are more common in pain problems. And then you have to talk to them afterwards. So there is an issue to look at. That, and that actually gave me a good idea there. We're going to discuss this in the steering committee of the database.
Yes, let me know. I'm very interested in this because we published our data just recently.
Yeah.
It's so difficult to get it published because it's too new, and everyone's uncomfortable with the idea that there may be like a mesh implant.
But there are Danish database studies that would combine the database for different autoimmune diseases and look at whether they exist in the hernia database. And then you could look at them compared to other hernia patients, whether they have more issues with the mesh or pain or whatever.
So we showed that we had two sets of patients. We had all the patients where we removed mesh because they were reacting to it. And everyone that got removed mesh for other reasons, hernia recurrence, meshoma, I think we took mesh infection out. So basically like a systemic response versus an actual mechanical or, surgical issue. And what we found was in the arm where it was due to mesh reaction, 80% of them had autoimmune disorder, weird allergies to things like food and clothing and environment and all that. However, in the arm where they had no reaction to the mesh, they just need it removed for another reason, there are plenty of people with autoimmune disorders. So we can't say autoimmune equals, we just know potentially it's higher risk. And I don't even know what that risk is. Is it 2% more? Is it 20% more? Is it 200% more? We don't know.
No, but we have databases that could probably answer part of that question.
Yeah. So here's a question which I think is a nice way to kind of wrap up, which the patients are online a lot reading about mesh problems. And it almost seems like everyone has a mesh problem, if you go online. But the data, your national database data.
Yeah.
So can you answer this question, which is posed, which is after all these facts and studies about mesh and its complications, why do you do this kind of repair?
Well, two reasons. First of all, we've shown that they have less recurrences.
Yes.
Significantly fewer recurrences.
Significantly.
Yeah. And the other is that even though that we look at this issue, people don't have mesh removed in that order that they do in the UK and in the US. And we don't
you barely have any patients. Yeah.
We don't have these issues. We have people with chronic pain, but we don't have these sometimes, when you see these things, the UK mesh, anti-mesh group, they are almost hysterical in their way of putting things and calling doctors Hitler and Stalin and whatever, Mengele, they should all be shot and stuff like that. It's completely crazy. And people, if you ask people in Denmark, do you want a mesh? They say, yeah, I'll have a mesh. And then there are very few that don't want to mesh. And obviously, right now, we have a discussion about whether young guys, even older than 18, should we just do a MRC with them, even with them, and do nothing, no mesh, and see what happens? Because there is issues about, that the young guys, that they are more prone to get pain, and they have a longer time of living with it.
Yes, correct.
The mesh is causing it. So we are discussing issues about this as well, whether we should do a study and try to compare kids, young men, and then tap for one and then MRC for another. Yeah. And look at them after a few years and see what happens.
Tissue repair versus laparoscopic with mesh. And what do you predict is going to happen?
I think that they will probably have this. I said, if you look into the pain problem after open surgery, I don't believe that the pain in the Liechtenstein is caused by the mesh. I think it's caused by open surgery.
I think the surgeons are at risk for a lot of these problems.
Yeah, so if that's true, whether there's a mesh or not, then it's not going to change but there are studies out there indicating that might be an issue, and that their risk of getting a recurrence is not higher. But that goes completely against our knowledge about mesh versus non-mesh in English.
Yeah. I mean, your data shows at 1 year, 10% have some type of pain, and the majority of that is not, almost all of that is not a mesh reaction issue. And at 5 years,
yeah, around 4%.
Around
And
4% of
five.
chronic pain, and even those
4-5.
people are not reacting to the mesh. It's like a stitch or too tight or like a balled up
Yeah,
mesh or
it's,
something like that.
Yes. And those
And
that,
what do you say to
those that have a severe reaction, they will be submitted to the decentralized unit that will look at them and see what they can do.
And what do you say to the studies that show a tissue repair is just as good as a mesh-based repair in terms of recurrence, like the shoulder studies?
Yeah, well, I believe that if you do something like shoulder ice 5,000 times, 5 guys, then you're going to be pretty good at it.
I think it's surgeon-based.
So there's no doubt about it that shoulder ice, if you would want a tissue repair, it would be shoulder ice and not Bassini, even though the Italians wouldn't agree.
Yeah.
That's another matter.
Yeah.
But still, I used to do shoulder ice way back, and I've been doing shoulder ice once in a little while. But there are so few asking for it now, and they typically go into the private practices.
Well, I'll tell you, I feel that a lot of it is, you know, I was taking out a lot of mesh from open surgeries. And I'm like, I wish more people would do laparoscopic, but now that more people are doing laparoscopic, now I'm taking out all these laparoscopic meshes. They're folded, they're bunched, there's recurrences. So my personal experience seems most of the reasons we see complications from mesh is surgeon-based. They use the wrong size mesh, they put it in the wrong area, they use the wrong type of technique, etc. And with time, I've noticed like women tend to have more problems. That's been shown in your studies and others with chronic pain. So I'm less likely to use mesh in a female, especially in the groin. Based on my own experience, people with known autoimmune tendencies or disorders or family history or allergy symptoms, I tend not to use mesh in them because maybe I'm helping them out. And they all understand that the tissue-based repair from a recurrent standpoint, and even a chronic pain standpoint in many cases, is inferior to the mesh repair. But for them, it may not be, you know, maybe okay for them to have a 7% recurrence rate, but have a less likely chance of getting sick from the mesh.
And then again, it ends up with, Sharon, if you have a long, reasonable talk with your patient, and they're fully informed and they make their own choice based on your information. Yeah. Then that's it. And then you can wait and see what happens. And sometimes, often enough, many times you'll be right, but other times you'll be wrong. Yeah. And they will come back and have complaints, and that's it. So I think that the whole issue here is information. Yeah. Yeah, and tailoring to the needs. Yeah, exactly. You need to, of course, you don't put in a huge mesh in a small person that don't need it. Right. And the tax, I mean, we don't do tax anymore. It's as I told you, it looks like that ProGrip might be the answer. Yeah, it's a good mesh. Yeah, I agree. Okay, that was a very intense discussion. We went overtime, Hans. Okay. Thank you for now. But thank you so much. Thank you so much for your time. Well, I'll see you in Barcelona in May. I hope to see you there. Yes. Okay. European Hernia Society, Barcelona, 2023. Yeah. So thank you, everyone. Thanks for joining us live on HerniaTalk. We'll see you next week. We have more fun guests. Okay. Make sure you follow me on YouTube, Facebook, and Instagram and Twitter. This will be on our site within a day. See you later. Thanks, everyone. Thank you again. Bye-bye. Bye. Thank you.